So good afternoon everyone and welcome to Insight 2020. This is our Festival of Analysis and Learning in Healthcare. Hopefully some of you have been to sessions before so you know what to expect, but if you haven't, we've got plenty more sessions to come which we'll talk about a bit more later on. Today's session we're talking about the analytical priorities for the Decision Support Unit network. So these are projects that the Strategy Unit team are going to be running over the next few months or up to a year. So we've got Stephen Wyatt, who's our Head of Strategic Analytics, and Jake Parsons, who's one of our analytic managers, here to talk to you a bit about how the projects were selected and also give you a bit of an overview of what the projects are. We're also going to be asking you some questions, so asking you to think about how you can apply these projects to your area and how can we make them relevant to you guys and what you're doing. And also if you've got any suggestions or would like to be part of kind of reference groups for the projects as well, we'll be talking about that later. As usual, if you could keep your microphone muted during the session, we will have some opportunities for discussion later on. So at that point, if you do want to speak, then you can. But while Stephen and Jake are presenting, if you could just keep your microphones on mute. But please do feel free to use the chat box. So put any questions in there as we go along, or introduce yourselves and make any connections with each other while we're going. So yeah, make the most of the chat box, and we'll be happy to answer any queries or pick up the questions at the end of the presentation slots. We're going to be recording this session and we'll be sharing the link with you afterwards. So if anyone's missed it or if you have to leave early, don't worry, the rest of the session will be recorded and available for you at a later date. If you'd like to tweet, we're using hashtag Insight2020 and do tweet us at strategy_unit. And yeah, we're keen to promote the festival as much as possible. So if you've enjoyed the time today, then please do share that on Twitter if you're of the tweeting kind. I'm now going to hand over to Stephen, and he's going to talk a bit about where the projects came from before handing over to Jake to talk about one of the projects. We are hoping that our colleague Paul will be able to join us, but he's unfortunately having some technical issues in that somebody's come to just edit the phone lines outside his house. So if he doesn't join us, then Stephen will step in, but we're hoping to have Paul as well later on. So Stephen, let me just hand over the remote control to you. Hopefully that will work.
Great, there we go, it's working. Good afternoon, everybody. So yeah, the session this afternoon, we're going to be just describing a little bit about the analytical priorities for the DSU network, what they are at the moment and how we arrived at them, and how you can influence future priorities. Next, we're going to talk through the 3 current projects that are ongoing at the moment. We're going to talk a little bit about the objectives, the methods that we're planning to use, and the planned outputs. And then during the session, we're going to be seeking your views about how to make those outputs as useful as possible. So if you have any thoughts or questions as we're going through, please just put them as comments in the chat box. We'll pick them up as we're going along, and there's a couple of spaces during the session to come back to the questions that you're asking. So one of the sort of core offers from the Decision Support Centre to the Decision Support Network is that it will carry out a small number of large-scale analytical projects each year. The analysis will be led by the Strategy Unit, but we'd be delighted to collaborate as much as there is appetite and capacity with the DSUs or with individuals in the patch. In each case, there'll be a regional report, there'll be a sort of main output, but there'll also be a specific output for each STP or ICS within the patch. And all the code that we produce when we're doing this work will be shared with the network. We don't have a hard and fast set of rules for what might be considered an appropriate project, but there's some guidelines. We're looking for projects that might be relevant to a substantial proportion of the region, or ideally the whole region. We want the projects to have some sort of ability to influence key decisions or decision-making processes. We're looking for topics that maybe haven't received as much attention as they should have in the past. Each project should probably be aiming to influence either or to explore issues relating to health outcomes or health inequalities, or the service efficiency of the services that we run in the health and care system. And obviously we want topics that are amenable to analysis, so we need to pick topics that we think can be addressed through good high quality analysis and data sets that might be available to us. can't seem to get the slide to progress. Oh, there we go. Good. So there's going to be 2 cycles per year. We'll start by seeking ideas from DSU network members on possible topics for analysis. So all we'll be looking for at this point is just an idea from an individual within one of the DSUs or from within one of the healthcare organisations within the patch, an idea for a piece of work we might take forward. All those work those up into a short outline, project outline for each of the ideas we get. So you don't need to worry about the production of any documents. You just need to come to us with your ideas either via email or give us a call, and we'll work them up into some sort of a mini outline specification for a project. Those projects then will be considered by the DSU network steering group. There's a steering group that's in operation, and each SDP in the patch has got a membership onto that organisation, and they will be asking that group to vote on the proposed projects using a single transferable vote system. So the current projects were selected by the steering group a few months ago, and we're going to commence work on those very shortly. The next round of ideas and projects will start shortly, around about Christmas time. We'll be looking for ideas from people for the next round of projects. So if you have any ideas, let us know. We'll start working on those. And the voting process should happen in the early part of the new year. So these are the projects that have been agreed for this financial year. So the first project that got underway about 8 or 9 months ago was a piece of work that a colleague, Justine Wiltshire, is leading on to explore patterns of healthcare use for the last 2 years of life. And that work is almost at completion. The last finishing touches are being added today and tomorrow. And Justine will be presenting the outputs on Thursday at a later DSU festival session on Thursday. So that piece of work is at the stage of reporting now. So there'll be a regional report and there'll be an STP or ICS report for each ICS and STP in the patch. And then the next set of projects, these are the ones that were agreed by the most recent steering group. There are 3 that have been agreed. There's going to be one that focuses on inequalities and access to mental health services for children and young people, and the consequences of poor access for later healthcare use and health outcomes. Andy Hood is leading that project. The second project is about classifying outpatient visits by function. And the third, which Jake Parsons and I are going to be working on, is going to be focusing on inequalities and access to planned care, what the causes are of those inequalities and what the consequences might be. So those are the 3 projects that we're working on in this round. We're aiming to finish those off. We're starting very soon, and we'll be finishing them off in April, May time, something like that. So we wanted to talk through a bit more detail about those 3 projects today. Get your thoughts really on how we can make sure the outputs that we produce are as useful as possible to you in the patch. Now, as I said, there's different people leading on each of these projects. Andy Hood's leading on the first one, the Mental Health Inequalities Access project. Paul Seamer's leading on the Classifying Outpatients Visits project, and Jake Parsons and I are leading on the Inequalities and Access to Secondary Care project. Andy Hood was due to be on jury service today, so we didn't think we were going to have him. So we weren't going to present in a lot of detail about that project. But I note that Andy is on the call. I think he heard on Friday that he wasn't needed for jury service today. So although we're not going to cover that project in any detail, Andy's around, and if you have any questions about that project, please post them onto the chat, and Andy will maybe provide some information on those a bit later. And as Lucy said, Paul's was due to talk about the Classifying Outpatient Visit project, but his telegraph poll is being taken down at the moment, so I'm not sure he's going to be around. So I'll do my best to sub in for him on that topic, but it's not, I won't do as good a job as if Paul were here himself. If he joins and wants to take over, that's great, otherwise I'll just talk about the project. And then Jake and I will talk about the last project, Inequalities and Access to Secondary Care project. So these are the questions maybe for you to consider as we're working through the slides. What is it that we can do to make sure that the outputs that we produce are as relevant and useful to you as possible? Secondly, If you're interested in joining an informal reference group for any of the projects, then please let us know. There won't be any sort of formal explicit requirements of you, but it'd be good for us to know if there are people out there in the patch who are interested in this topic, who might be interested in looking at some early drafts or helping us to resolve some either methodological or assumptions that we need for the project, then we might approach those informal reference groups at that point. And finally, maybe thinking about how, at the end of this process, when the reports are being produced, are there particular projects or initiatives available running in your STP that you could link these projects into to make the most of them and get the biggest impact from them? So those are the sort of questions for you to consider as we're working through. Any thoughts or questions, please post them in the chat as we're progressing. So I'm just checking Paul isn't on the call, is he, Lucy? You can't spot him anywhere, can you? I can't see him, so I
can't see him, I'm afraid not. So I think
I'm going to do my best to cover Paul's project and describe what he's going to be doing over the next 6 months. So the objective of this project is to classify outpatient visits by function. So outpatient visits, well, we know they're highly numerous. I think there's about 120 million of them carried out every year in England. They're also increasing quite rapidly. The rate of growth in outpatient activity is considerable. And finally, the costs of outpatient attendances are considerable. I think we spend about £10 billion worth of NHS money on outpatient attendances every year. Lucy, I'm really struggling to advance the screen. I'm clicking on it, but it doesn't seem to be moving. Would you mind taking back control? There we go, great. So yes, we spend about £10 billion of the NHS budget on outpatient attendances every year. Now there's been quite, for some time, sort of rumblings in the policy world about the need to redesign, to re-engineer, to rethink the way we deliver outpatient services. It's seen as quite an outdated mode of service delivery. And it's thought that there's quite considerable opportunities for service efficiencies to be gained and for outpatient attendances to be organised in a way which is much more convenient for patients as well. But despite that, we've seen very little change in the pattern of outpatient attendances over the last few years until coronavirus came along. And then almost overnight, we saw a massive increase in the proportion of outpatient attendances which were delivered by telephone or video consultation. So this kind of suggests that there is really an opportunity to do things differently, and what we really need is some good incentives to bring that about. So anybody who's done work on outpatient data kind of knows the current state of play. We get a record that's created every time an attendance is scheduled, an outpatient attendance is scheduled. Certain demographic information about the patient is kept along with some administrative information, but there's remarkably little clinical information in the outpatient data set. And there's also nothing which gives an idea of the intended purpose of the visit. And we think through some data linkage and some analysis, we can derive some information about the objective of the outpatient visit, the outpatient attendance, and that might be really useful information to help people who are in the space of trying to redesign outpatients. The Royal College of Physicians did some work to try and describe the range of functions that are carried out in outpatient attendances, but we think we can possibly take that work a bit further. So we want to develop an algorithm, a set of rules that we can use to classify outpatient visits by function. And the types of things we want to be able to assign an outpatient visit to here is whether the outpatient visit is primarily interested in diagnosing a patient's condition, whether it's about managing a patient's long-term condition, whether it's about a surgical intervention, whether it's conducting some sort of pre-operative assessment or post-operative review, or whether the purpose of the outpatient attendance is for some urgent investigation. So we think through some investigation of the data sets themselves, but also through some linkage so we can see an outpatient visit within the context of the wider patterns of care that the individual is receiving. We think we can have reasonably good to go at trying to assign attendance to each of those functions. Once we've got the algorithm working satisfactorily, we'll attempt to quantify the scale of activity by STP, hospital, specialty, and by function. And then we want to try and add some more descriptive analysis around that to provide a bit more contextual analysis. It's worth saying that our primary objective here is not to try to correctly classify every single outpatient attendance. We know that's not going to be possible from the data sets we've got, but rather to give some sense of scale about the relative numbers of attendances by function that can be used to support redesign activities. So this isn't an algorithm that can be used for pricing, for example. We don't think it will be good enough to support any sort of contractual or pricing mechanism. But we think it might be useful to give people a sense of scale in terms of redesign activities. So we're going to start off with a literature review. Other people have done work on this topic already. We want to make sure we take account of the work that they've done. Second stage for us is to develop and test a series of algorithms to try and assign the work correctly to each function as best we can. Now, we haven't got a data set, obviously, against we can compare the right results to, but we can get some clinical perspectives on the sense of scale we're getting for each function. Then we're going to apply the classification systems to the outpatient data and produce some descriptive analysis of the results. And our outputs will be a sort of detailed written report, regional written report, setting out our methods and data sources, results and conclusions. But we'll also produce a report for each STP in the network, scaling and interpreting the results for its local population. All of the results will be, or the code, I should say, that's used to produce the results will be shared on GitHub and will be available to BSU network members. And alongside sort of reports or presentations that we'll run to share the policy implications with those leading maybe service redesign activities. We'll also run some workshops for BSU network analysts to explain how we've arrived at the results that we have. We'd like, ideally, for people to take on the work that we've done to take it in a different direction, or to take it further in particular areas or in more detail, to carry out some more local analysis. And if you can build on the code that we've already produced, then that's clearly an efficiency gain for the system. If we think the results merit it, then we might seek peer review or a publication in a peer review journal. So that's the idea for that project. I'm wondering whether we might stop for some questions via the chat box and try and address any questions or questions that you might have at this stage, or any comments you have about how to make the results more useful or meaningful. So I've got a note that's just come through from Alison. Alison Turner in our team is going to be conducting the literature review for this project. It sounds like they've just started the Medline search and we'll be looking at grey literature sources next. Does anybody else have any sort of thoughts or questions that we need to pick up at this stage, or shall we move on to the next project?
Sorry, I've come in on the microphone because I'm not quick enough on the text. So it's Johan Batty in the CSU. I'm just wondering, I know it's prejudging the literature review, but it's some of the decisions that made that around doing this. So what was really pushing it?
You mean the objective of the project?
Yes, yeah. So I mean, recognise the need for it, but sorry, what you're trying to do. But why is this? I want to understand a bit more about why this is such a priority, if you like.
Well, we've got broad ideas in that respect when we went to the DSU steering group, and I guess they had their own ideas about why this might be useful. But it does seem like there's been some pressure on systems for some time to do redesign activities in outpatients, and people are maybe struggling to get some traction in that area. Over and above the agreeing with the principle that there's room for manoeuvre in terms of efficiency gains in outpatient attendances, then strategies to bring that about are more difficult. And one of the things that I think people are lacking is really robust data on which types of, or which subsets of outpatient activity could really be delivered through some telephone or video consultation, and which really fundamentally can only be delivered through some face-to-face consultation because of the kit that's required, or because of the intervention where the clinician needs to be in a face-to-face setting. So one of the things that we're hoping with this project is that it might shed some light on that particular angle. Which of these attendances could really be done in some virtual mode, and which really require traditional face-to-face service delivery. So I think that was the kind of the conversation at the reference group when this project was prioritised. I hope that gives a bit more context. Is that useful?
Yes, that's very useful, because for me that would have been one of the major things about that redesign, and particularly around the virtual appointments. So I'm really interested to see how this plays out.
Right. I mean, we're at this is one of those projects where we're taking a bit of a punt in terms of the outputs that might come out. I mean, we're speculating based on a bit of work we've done in the past that we think we can produce something that's useful here. But the proof of the pudding will be in the eating, really. I'm backing ourselves that if we spend a few months looking at this, then we can produce something that might move the debate on a little bit. But we can't obviously guarantee that until we've got into the detail of the work. But nonetheless, I'm hopeful. I think we can produce something that could be really useful.
Oh, great. Thank you.
Shall we? We just got a note from Carl Bridges. So, Carl, you were saying that you've been using Upstream Health for analytics. Is anyone else using them? Is that particularly in relation to this outpatient redesign issue, Carl? I think Carl's asking whether anybody else has been using that organisation. It's not an organisation I've come across, but and then Fiona's pointing us towards some COVID-related redesign work that's been done in the Northwest for outpatients. So I'm wondering, Alison, whether you might try and aim to pick up on some of that through your literature review, the Grey literature review, whether you could try and spot the work that they've done and help us understand where they've got to. Okay, great. I'm going to maybe hand over to Jake now, who's going to talk about the second project, the project about inequalities and access to planned care.
Thanks, Stephen. Just to see if this is working. Okay, yeah, I think that's working now. Okay, so the second project that we're going to look at is trying to understand inequalities and access to planned care, and what are the causes and consequences of that. So in this context, what we mean by planned care is essentially elective care, and that can be used to describe a whole range of interventions that are delivered to patients on a planned basis. And these usually take the form of maybe an outpatient consultation, a diagnostic test, or some form of planned surgery, whether that's day case, inpatient, or perhaps an outpatient procedure. We know that elective care is supplied at different levels to those living in more deprived areas, typically lower levels to those living in deprived areas. And we know that differences in access to elective care are growing. Obviously, inequalities exist for many different population groups, not just those at different levels of deprivation, but for ethnicity and many other groups. For the purpose of this project, we're focusing solely on deprivation. So just to kind of give you a bit of context, the process that leads to a patient receiving some form of elective care can take several forms, but typically would take the following path. So a patient would experience some symptoms. They may then decide that they need to see their GP, or they may not. They'll arrange GP appointments. At that appointment, the GP will examine them, maybe carrying out some basic clinical tests, and on that basis will decide whether they think a referral to a hospital or a hospital consultant is required. If they think it is, an initial outpatient appointment is arranged with the consultant or at the hospital. Within that outpatient appointment, there might be an examination by the consultant, and they may undertake or request a series of diagnostic tests. On the basis of that, they may or may not then decide that some form of treatment is required. And that could take, again, many different forms. So it could be some form of therapy, it could be a medication regime, some form of elective surgery or procedure, and potentially some follow-up consultations. And it could be a combination of any or all of those things. Those activities typically take place in an inpatient or outpatient setting and can take place over many weeks or months. And the consultant is responsible for deciding when that patient's care is complete and refer back to GP for ongoing support. Now, obviously, you can see that within that whole process or pathway, there are many, many opportunities for inequalities in access to occur. So it could occur right at the very beginning as a result of perhaps patients' choice of deciding when or if they decide to seek support from the GP, or it could occur later in the process, so GPs may make different decisions about whether a patient is suitable for onward referral. And similarly, at the stage of the consultant appointment, the consultant again may make different decisions about what the best course of treatment or ongoing support a patient might need. Trying to understand where in that process those inequalities might occur, and the scale of those is obviously really important if we're to understand how we might address some of those inequalities. The second aspect of this particular piece of work looks at, we know that in contrast to the experience of elective care, patients living in more deprived areas have much higher levels of access to unplanned or emergency hospital care, in particular emergency hospital admissions. We know from the research that there are a number of possible reasons or drivers for this, including poorer access to primary or community care, the quality of chronic disease management, and a range of other drivers resulting in high levels of emergency care. One of the alternative hypotheses that perhaps hasn't been so clearly investigated is the suggestion that perhaps increased rates of emergency hospital admissions are driven in part to poor access to elective care. So the fact that people aren't having, people from poorer areas have lower levels of access to elective care, and that results in them having to seek emergency or non-elective care at higher rates. We think if we can establish such a link, it might point to different strategies that commissioners and providers might adopt to try and reduce levels of emergency hospital admissions in the future. So the objectives of this project are threefold. First one is to review the evidence relating to equalities in access to planned care. The second one is to try and understand where in the process from symptoms emerging to treatment in secondary care those inequalities emerge. And thirdly, to establish the extent to which poor access to elective care leads to higher levels of emergency hospital admissions. And there are three reasons why we think this might be useful. We think it'll shift the debate away from just the whole population waiting times issues and onto helping us understand where the inequalities in access to secondary care might be. We think it will guide the debate about how we might reintroduce planned secondary care following the COVID outbreak, such that we might do things differently if we approach it from a slightly different perspective, looking at inequalities rather than just pure waiting times. And thirdly, we hope that having better understanding of whether access to planned care has an impact on non-elective care might provide some more insights to help people think about how we might address some of those things. So in terms of the methods that we're going to be using for this, the first thing we'll be doing is trying to understand what the evidence tells us. So what's the most recent evidence around inequalities in access to planned care? So we'll be undertaking, our colleague Alison will be undertaking an evidence review looking at the recent published evidence around that area. The second aspect of the work will be to try and understand where in the patient's journey do the inequalities in access emerge. So as I mentioned previously, there are a number of points where inequality might emerge. And the causes of that inequality will differ according to the population concerned, and also whether in relation to the particular condition or treatment that's being required. Our analysis is therefore just going to focus on somewhere between 3 and 5 conditions or trace conditions that frequently result in the requirement for medical or surgical treatment within secondary care. And we'll draw those trace conditions from a long list of potential candidates. For each of those conditions, we'll quantify the number of patients within each deprivation decile who progress at each stage of the pathway. So how many progress from symptoms to a GP appointment, how many then get referred to an outpatient appointment, and then how many end up being treated in various ways. And we'll use a baseline indicator of need to help us calculate and illustrate the average stage progression rates along the pathway, both overall and also for each of the deprivation decile groups, so we can begin to see where those differences are. We'll quantify and illustrate those in absolute terms, such that we'll be able to show what level activity would need to be seen within each of the deprivation groups if access was actually equal or proportional to that baseline need. And we'll select a single measure of inequality so that we're able to compare differences both between conditions and different points of the pathway. I'm going to pass you back over to Stephen now, who's going to talk about the third area of the analysis for this particular project.
Yeah, so we're going to start when we're trying to consider the relationship between levels of access to planned hospital admissions and unplanned hospital admissions. We're going to start with a basic exploratory analysis using some simple techniques to try and give us some visual sense of what's happening in this space. So we'll be using statistical process control to look at special cause variation over time, but also across different geographies or social groups. And we'll be using standardization just to see the extent to which we can explain away the variance we're seeing through the different age profiles of different groups across the country. We've got pretty good national data on most of the things that we're going to be looking into here. We've got long-run PES data sets that we have access to that will help us spot changes over time and variation between geographic areas and social groups. But the more detailed analytical work that we'll be doing, we'll use an approach called panel data regression, which I'm sure a number of you are familiar with. I'm struggling to advance the slides again here. Thank you very much. So if you can imagine plotting the time series of unplanned admissions and planned admissions. Both would see an increase over time. And if you were just trying to draw a sort of causal conclusion from the two of those time series, then you might conclude that increases in planned care might lead to increases in unplanned care. But I'm sure you wouldn't be persuaded by that sort of analysis. Similarly, if you were to plot, maybe after adjusting for age and sex, rates of elective admissions and emergency admissions, you probably see a negative correlation between those two metrics when cut across different geographical areas. For example, you probably see those areas that have higher access to unplanned care have lower access to planned care, and vice versa, and maybe draw the conclusion. You might be tempted to draw a conclusion at that point about the causal relationship between those two things, but I think you'll agree that either looking at purely on a time series basis or a cross-sectional basis like that doesn't give you enough confidence in the causal connection between those two metrics. So the panel data regression method that we're planning to use puts those two perspectives together into one analysis, so you get both a time series and a cross-sectional perspective on the data. And that helps control for a range of unobserved or omitted variables that might otherwise confound the relationship you're trying to test. So essentially the panel data regression method says, are those areas that have seen the greatest increase in planned care admissions the same areas that have seen the greatest decreases? Or sorry, it's the same as the areas that have seen the slowest increases in emergency admissions. It's essentially what the panel data is seeking to, panel data regression is seeking to answer. And we think we've got the data that might support that sort of analysis. This will obviously be an observational study design, so we'll have to think hard about other possible explanations for the results we're observing, other confounders that we haven't been able to control for example. And fundamentally, this analysis remains an ecological study, so we might be seeing relationships between those two variables at a population level, but that wouldn't be enough per se to allow us to draw conclusions about whether those effects would also be observed at a patient level. Whether if a patient had some form of planned care, then they might have avoided a piece of unplanned care. So one of the things we might try and do, just to give us a bit of greater confidence in the results we're getting, if you could put the slide on again for me, Lucy, would be to repeat the analysis for specific clinical conditions or clinical disease subgroups. So if we can also spot this same relationship happening within just planned and unplanned cardiovascular admissions or planned or unplanned respiratory admissions, that might give us a greater confidence that this relationship might hold at a patient level. So that's roughly the analysis that we're planning to perform. The panel data regression, there's a number of forms it can take, at least 3 competing methodologies that are out there, but there are standard diagnostic tests to help you decide which of the 3 approaches to use. Similarly, there's going to be issues about lagged effects. How long after an increase in planned care might you see a slowing of rates of unplanned care? And again, there are sort of standard methods for spotting and determining the level of lag that you should use in these sorts of analyses that we'll use. We'll also be guided by the literature where that helps us determine some of the answers to these methodological questions as well. So the outputs for the project, as before, we'll see there'll be a detailed written report for each for the region as a whole, but we'll also produce an output for each STP and ICS within the region. And again, we'll try and scale the results so that each STP gets a sense of the impact it might have on its population, the relevance it might be for its population. As before, we're producing all the R and T SQL code that we produce for the project will be made available on the GitHub page. And we'll be running a workshop for DSU analysts to sort of describe the methods and the codes. And as before, if we think there's room for a peer review article here, then we'll consider submitting an article to a peer review journal or a trade journal. So I think that's all from me now, Lucy. Are we going to move into breakout rooms next?
Yeah, I think that's the plan. But before we do, I'm just wondering if anyone has any questions for Jake or you on that project. Again, people feel free to put them in the chat box, but also if you'd rather speak, at the bottom of the participants list, there's a little kind of green tick that says yes underneath it. So if you'd like to ask a question verbally, if you just click that, and then I know who's waiting, and so we don't have everyone trying to speak at once. So does anyone have any questions for Jake or Stephen on either of the projects presented? Fire Tablet Benjamin, I can see you've got a hand.
Hi, yeah, can you hear me?
Yeah, loud and clear.
Okay, and can you see me as well?
Yeah.
Yeah, lovely. It was just really just a follow-up question, really. It's been a really interesting presentation, well, both interesting presentations. I'm just wondering, from a point of view, that as a next step on from this, is there a sense in which we would be able to, I suppose, sort of, take, sort of the outputs from this and sort of, refocus them? I'm just thinking from our point of view, sort of, we've been thinking about the impact of not just sort of local deprivation, but also obviously there's been an impact from COVID as well around regulation, treatment and emergency treatment even. So it's sort of in point of view of I suppose seeking permission, if you like, to sort of maybe rob some of the key messages, so that we might be able to learn some lessons here in our local patch.
Absolutely, yeah. I mean, that's sort of music to our ears, really. We want the outputs to be as useful to people as possible, and if we can shortcut some of that process by sharing the code and the outputs, then that's fantastic. If you think there might be, I mean, now's a good time to suggest, either now or the next month or so, to suggest if you think there are just subtle ways we can change the outputs to make the results particularly useful to you, then please let us know. That's the kind of stuff that we're looking to hear. But obviously the DSU steering group have selected the topics, so we're kind of obliged to follow through on the topics they've given us. But if there are subtle changes to the projects that make the outputs really useful to you and fit in better with local projects that you're working with, then now's the time to tell us. We'd love to hear about them.
Yeah,
I mean, one of the ways, Benjamin, is to maybe twisting around a bit, but is to offer to be part of one of the informal reference groups for the projects, and then we can make sure you're looped in as work progresses, and you can steer us as the project progresses as well.
I mean, whether it be me or one of my colleagues locally within health, it's a conversation that I can have. But I think it's something that I'm going to take back now. Obviously, having that conversation locally, and because I think that there could be some useful stuff there.
Right.
Yeah, lovely. Thank you.
There was a comment from Gareth about supporting local interpretation for anyone conducting their own subsequent analysis would be really useful. And I've just posted the questions in the chat box. So if anyone has any, what we'll do now is we'll just split you into small groups to have a bit of a chat in smaller groups, and then feedback. But if you've got any comments, answers on the questions, feel free to post them in the chat box or raise your hand now. I've just had one more thought though, before we do that. Is it too mean to put Andy on the spot and say, would he just give a very brief spiel about the mental health project? Andy, are you still here?
I am still here, Lucy, yeah.
Is that too cruel? Could you just give a very brief sort of summary of what you're doing in the mental health project?
It is cruel, but I'll let it ride, that's fine. Although I won't turn on my camera because I'm feeling particularly rough, as well as being in jury service limbo. But yeah, so as Stephen suggested very early on, that so one of the three projects is around sort of inequalities in access to mental health in children and adolescents. So there's several strings to this particular project. There's some quantitative, there's some qualitative, and there's also some bits around the evidence as well. I'm hoping to package it all up, I suppose, to be a supportive guide, stroke action plan for commissioners, people who are looking at children and adolescent mental health services. So on the quantitative side, we'll be looking at kind of published data on sort of access related measures around children's mental health services. For example, the national standards on sort of targets to try and get more children into adolescent mental health care. We will also be sort of deep diving into the data now that the national mental health data sets have kind of caught up with CAMHS in a sense. Since January 16, they've started capturing all of that data, so we can have a look at much more specifics, look at the variation at a very local level, looking at sort of, you know, socio-demographic characteristics, all those sorts of things based on raw data. We'll also be attempting to do a fairly ambitious cohort type study. Again, acknowledging we're looking at not necessarily the younger end because of the data, but we'll be looking at a 10-year period, so we're looking at adolescents and young adults who've been within services over a long period of time, and kind of, I mean, it's not fully agreed on the methods yet, but some kind of way of identifying those factors throughout that 10-year period, which have sort of impacted particular outcomes, which we'll be monitoring over the time, things like early deaths, self-harm, admissions, those kind of things as well. So trying to pick out, again, sort of data-driven factors which are suggesting, you know, certain areas need particular exploration, investment and so on. We're trying to kind of tally that up with the evidence as well. So Alison and colleague Richard as well has started to feed through information on various published studies, surveys and grey literature around the topic as well about why sort of young people don't engage with mental health services. So we're trying to triangulate those kind of things in as well. And then some qualitative again. So people, other colleagues at the strategy unit are going to be running a fairly large scale survey, leaning quite heavily on our ICS and STP colleagues to try and get a really good cross section of people involved who can give a richness of qualitative information on why people may or may not access particular services for particular reasons. So again, thinking about sort of operational leads, clinical leads, service users, commissioners, public health, people in prevention. So looking at a whole range of sort of aspects, really, different perspectives on the issue. And again, trying to triangulate all those to come up with what we think hopefully describes what are the current issues, what are the prevailing issues, and potentially future issues that can be resolved. A slight, I suppose, added value thing around the evidence, we're also going to hopefully try and look at not necessarily making the economic case for, but trying to understand what the economic issues are around sort of early intervention versus sort of treatment and management in later life in terms of mental health. So again, I suppose trying to support investment plans, support bids, support thinking around commissioning of sort of prevention over treatment services, I suppose, really thinking about how can we maximise the sort of the money that is currently being invested and future investment in mental health. So it's a pretty ambitious, quite very broad topic, but yeah, we're hopefully trying to cover many angles and sort of gathering lots of data. Again, as Jake and Stephen have said as well, we're happy to share any of our code which we've used to derive our sort of cohorts, derive any of our metrics and measures that we're going to analyse in more detail as well. So yeah, I think that's probably enough. Apologies, I didn't get to throw together more of a descriptive package for everyone to understand, but of course I'll be around either in the chat box or available for a chat later if people want to understand a bit more about what we're hoping to do over the next sort of 4 to 5 months on that project. Thank you.
Great, thank you very much, Andy. So we now want to take this opportunity to ask you guys for some feedback, mainly in the 3 questions that Stephen posed at the start. So how can we make the outputs as relevant as possible? Would you be interested in joining an informal reference group? And are there any initiatives in your STP area that you can link these projects to? So rather than kind of making you all shout at once, what we're going to do is split you into 3 groups, and I'm splitting Stephen, Jake and Andy between the 3 of them, and so we'll just be able to have a bit more of a chat. And also, if you've got any questions that you want to ask any of the 3 of them directly, then yeah, you'll have the opportunity to do that in these smaller groups. So I'm just going to post the questions again so that you've all got them at the bottom, and then I'm going to send you into small rooms for about 5 minutes. And then we'll come back together and I'll talk to you about what's happening for the rest of the week. So bear with me 2 seconds. Hello, have people made it into the breakout room?
There's a few of us here, I think, Lucy, yes.
Great.
Yeah, I'm here. Yeah, I'm
Fab. Does anyone have any thoughts that they'd like to share? Particularly around, I think, local initiatives and actually how you might use the outputs of the projects.
I think for us locally, as I think I sort of inferred in the question that I asked in the main forum, was that, you know, there's a lot of work that's going on for us, like I'm sure there is for a lot of other people as well. It's not just, you know, sort of catching up with what's been happening, you know, sort of, or not happening, more to the point, you know, since March, and also sort of thinking ahead in terms of what the impact might be of things not happening again, you know, in December and January, possibly, depending upon what happens. I mean, obviously we do, as per the presentation, we do see that sort of impact of, you know, of the sort of the, you know, the elective and the emergency care in terms of access. And one of the things that we want to do as an integrated care partnership locally is to level up that sort of playing field so that everybody gets that opportunity for having a healthy and fulfilling life, which is not the same for everybody. You know, what some people would regard as healthy and fulfilling is not what everybody regards healthy and fulfilling. But I think certainly from our point of view, it'd be really useful. And as I say, sort of, there are colleagues locally who are working on that, but I think that's really, I think probably for us, as with most people at the moment, is sort of is understanding where we are, but also how it'll help us sort of, you know, sort of fill the gaps.
Yeah, great. That's really useful. And yeah, I think we're aware that lots of people are in similar positions, and it's the planning stages that, yeah, coming fast upon us. So hopefully that the projects will be useful, and we'll, yeah, bear that in mind when we're doing the outputs and things. I don't know if anyone else had any examples they wanted to share or thoughts.
It's gone quiet.
Quiet, yeah, it always does. I think I might draw us all back together, because I think I'm aware people are quite busy at the moment, and so it's been lovely to have you all here. I'm just going to disappear, and then I'll pull you all back in a bit. So see you shortly.
Okay.
Hello, somebody's just joined. We're just everyone's in breakout rooms, but we're just about to come back together. So the meeting will be resuming shortly. If you want to hang around, bear with me 2 seconds. Right, I think that looks like most people are back. Oh no, it doesn't. No, the other groups are still talking. It's just our group that's all a bit quiet. The link that I'm sharing on the screen is for the where you can find the project, more detailed version of the project outlines, and I'm just going to copy and paste that into the chat box now. Right, that looks like we have got everyone back now. Welcome back, everybody. I'm just saying to those that were here a bit quicker, the link that is showing on the screen at the moment is where you can find a more detailed description of the project outlines. So I'm just posting that into the chat box now. Oh, Steve's done it too. It would be great just to hear any thoughts that you've had. Just if you could put those in the chat box while I'm talking about what's happening later on this week. So thank you very much for joining today. Oh, we're missing a couple. Tomorrow, which isn't on the screen, we have a session run by the strategy units Paul Mason and Abby Muller on qualitative findings from COVID. So that's based on some work that they did with some GP practices in an SDP near here. In terms of finding out, they carried out interviews all through, I think it was from March or April through to the end of June, and trying to capture people's experience of actually living through COVID and what it was like in terms of the qualitative changes that people were experiencing. So they're going to be talking about their findings from that, which was particularly interesting in terms of how teams are working together and innovating and adapting, and I think so really interesting session that's going to be. On Wednesday, we have a meeting about the future of analytics, which is with Gareth. I'm not sure if Gareth is still here, but that's going to be a panel discussion on where the direction of analytics is going and how can we make the best use of analytics moving forward. On Thursday, we've got Justine sharing her findings on the healthcare use in the last 2 years of life. So that was the first project that Stephen that we've been doing under the DSU banner, and again there's some really interesting findings coming out there. And then finally on Friday, we're talking about actually what can the DSU network be doing to support analytical work and to support what should the priorities be moving forward. So do tune in to any of those. If you'd like to book a space, I'll just copy the link into the chat box there. If anyone else has any final questions or comments that you'd like to make, again, feel free to just put them in the chat box or raise your hand, and we're happy to have some discussion. I can see some people are putting things in. Talking about the importance of considering solutions, outpatients at age, technology deprivation status appropriate. Helpful.
I just want to pick up on a point, Lucy, that Johan's made about how I'll be sharing the preliminary findings.
Yeah.
So it's our plan to share the preliminary findings for each of the projects with the DSU steering group, and each STP and ICS is represented on that steering group. We also have representatives from Public Health England on that group and NHS England Director Commission Services team. And we'll also be sharing the preliminary findings with the informal project reference groups as they become available for thoughts and comments on the findings as they become available. We've got absolutely no intention of just dropping this out on systems without the systems being aware that it's coming out or having plans to deal with it. In fact, we'd rather local systems manage the communication of the outputs through their system. I think that would be our preferred approach. So rest assured, we're not just going to drop this, you're just going to wake up one day and find the outputs being published in your STP without any warning. That's not the way we want to run things or the way we intend to do things. We know how disruptive that could be.
Johan's just asked a follow-up question on timeframes for the outputs. Do we have any preliminary timeframes?
Well, yeah, so just to remind you that the end point for the projects will be March, April 2021. But we'd be hoping that some preliminary outputs will be available around about New Year's time. So we should start seeing some of the preliminary outputs around that time, depending on how the projects progress.
Great, thank you. So unless anyone has any final questions for Stephen or Jake, if you do, then just raise your hand or flag now. I'll give people a couple of minutes to do that, but otherwise, thank you very much for coming, and we hope you enjoy the rest of your days. And thank you very much, Jake and Stephen, for your presentations, and Andy for being put on the spot there. A question about the reference group. Is that the timelines for the reference group, Johan, or?
Yeah, certainly. If you're interested in being a member of the informal reference groups, then just drop us an email or put your name on the chat and let us know now. I'm sure our contact details are available, but or you could give us a ring by all means. Whatever's easiest, just get in touch with us and let us know you're interested.
Do we have a time? When are we looking to start those? Will that be in December, January?
No, we probably want to get those up and running around November time.
November time. So they'll be up and running from November. Great. Okay, thank you everybody, and hope you all have a good rest of your day.